Hello, welcome to our attendees here in the U.S. and around the world. Thank you for joining us for today's Nova Biomedical webinar, Glucose Meter Accuracy and Capillary Blood Testing in the ICU, Why It Matters. Our speaker today is Dr. Brad Karon, Professor of Laboratory Medicine and Pathology and Chair of the Division of Clinical Core Laboratory Services at the Mayo Clinic in Rochester, Minnesota. We'll also hear from Dr. Naveen Bangia from Nova's Medical and Scientific Affairs Department to discuss ketone testing as an important counterpart to blood glucose testing. My name is Rick Rollins, Senior Marketing Manager here at Nova, and I'll be moderator for today's event. You can post questions during the webinar using the Ask a Question tab on your webinar console. We'll address these questions following the main presentation and follow up with a full list of questions and answers shortly after the webcast, including those questions that we may not be able to address in today's session. This webinar has been approved for 1 contact hour of PACE Continuing in Education credit and 1 CERP unit by the American Association of Critical Care Nurses. For participants in one of these organizations, your CE certificate will be emailed to you once you complete a post-webinar survey. A link to this survey will be sent to you just after the webinar concludes. If you fail to receive our email, please be sure to check your junk mail folders in your email system. And visit our website to register for future live events and to explore our wide array of on-demand content, with topics including clinical testing, cell culture, and veterinary diagnostic testing. You can subscribe to receive notice of future NOVA educational webinars. You'll also find more information about whole blood critical care testing products on the NOVA website. And now, on to our main presentation. Dr. Brad Karon is a professor of laboratory medicine and pathology and chair of the Division of Clinical Core Laboratory Services at the Mayo Clinic in Rochester, Minnesota, where he was also recently named Dean of the Mayo Clinic School of Health Sciences. Dr. Karon is a fellow of the College of American Pathologists and serves on the organization's Board of Governors, as well as chair of the Council on Scientific Affairs. He is a fellow of the National Academy of Clinical Biochemistry, which is now the AACC Academy, and has served as an advisory panel member for the FDA and Clinical Laboratory Improvement Advisory Committee, managed by the CDC. Please welcome Dr. Karon.
Thank you, Rick. I'm Brad Karon, Professor of Laboratory Medicine and Pathology at the Mayo Clinic in Rochester, Minnesota. I've been either director or co-director of our point-of-care program here for about 18 years now, and one of the main focuses of my academic career has been looking at this issue of glucose meters, glycemic control, and executing glycemic control protocols in hospitals and intensive care units. Today I'm going to talk about glycemic control and glucose meters. And the title of my talk today is Glucose Meter Accuracy in the ICU, Why It Matters, and What About Capillary Blood? For disclosures, I'm a consultant for Nova Biomedical, and Nova did provide travel support for a presentation. So our goals for learning today are to list the factors that impact the accuracy of glucose meters in the hospital and critical care environment, describe variables that can affect the efficacy of hospital glycemic control protocols, discuss the limitations and concerns around the use of capillary glucose sampling for critically ill patients, and review pooled capillary glucose accuracy data for one device when it was used in critically ill patients. So we know that glucose meters have been used for decades and decades, both in the home and the hospital. Focusing on the hospital use of glucose meters, they can be used to dose subcutaneous insulin for diabetic patients who are mildly ill. And just as in the home, the accuracy requirements are not tremendously stringent in order to arrive at accurate subcutaneous insulin dosing. Glucose meters are sometimes used to screen for neonatal hypoglycemia, which would be the subject of a whole nother hour or so talk, so we're not going to cover that today. They can be used to screen for hypoglycemia and hyperglycemia in hospitalized patients, and there are multiple endocrine and critical care groups who recommend that. Interestingly, the exact accuracy requirements for that use haven't been studied or defined as much as other uses. And they can be used to manage intravenous insulin for critically ill patients on a glycemic control protocol. Usually these patients get hourly glucose or every other hour glucose measurements and have adjustments to an intravenous infusion of insulin. This carries with it narrower insulin dosing ranges and generally, although that trend has evolved to have a little wider glucose targets, narrower glucose targets than subcutaneous insulin dosing or other uses. So what is this glycemic control all about? Well, just a trip down memory lane, or maybe for some of you who haven't practiced as long, you don't remember that glycemic control is still relatively new in terms of modern medical care. Before the early 2000s, really no one cared about glucose levels in the hospital. If glucose got really, really high, you might give a little subcutaneous insulin. But this randomized trial in 2001, Leuven 1 by Dr. Vandenberg, really fundamentally changed the approach to glycemic control in the ICU almost overnight. And for those of us who were running point-of-care programs in the early mid-2000s, the landscape changed under our feet. This study took ICU patients in a surgical ICU, randomized them to what was at the time conventional glucose control. For surgical ICU patients, if the glucose got above 215 or so, you gave a little subcutaneous insulin, but you really didn't care about glucose levels after surgery. The other arm was the intervention arm, had glucose levels maintained in relatively normal levels, 80 to 110 milligrams per deciliter, so a very profound intervention. The results of this study were shocking, looking at 30% decrease in ICU mortality and 40 to 50% decrease in bloodstream infections, renal failure, and red cell transfusions. That kind of intervention, no other intervention has that effect on mortality or morbidity in the ICU. And so it really changed the landscape overnight, and everyone wanted to have effective glycemic control in their surgical, and we'll talk about medical ICUs. Noteworthy, when you do a lot of intravenous insulin, the rates of hypoglycemia increased. And the intervention arm had a 6-fold higher rate of hypoglycemia than the control arm. But the overall rate of hypoglycemia in the intervention group was only about 5% of patients experienced severe hypoglycemia in this first landmark study. Moving ahead, the same group produced a second study in 2006, also published in the New England Journal of Medicine, as was the first. Really repeated the study, but in a medical ICU, not a surgical ICU. In this study, they found that this tight glycemic control strategy was only effective in patients who stayed more than 3 days in the ICU. They found, as consistent with the first study, a 6-fold increased rate in hypoglycemia, but note the overall rate of hypoglycemia, almost 20% of patients experienced severe hypoglycemia. And noteworthy, they used arterial blood gas analyzers to do all the glucose measurements in the first study. They used glucose meters in the second study, and that produced a lot of speculation. Was the use of a less accurate device, a glucose meter, responsible for some of this increased hypoglycemia and not as significant outcomes of glycemic control in the surgical ICU setting? Subsequent studies had mixed effects, but over time, basically, it's been found that this tight glycemic control probably isn't the way to go, and that the goal is that you want to, control glucose levels to some extent below somewhere around 50 to 180 mg per deciliter, less than that, depending on the institution, but in a way that doesn't increase hypoglycemia so much. And the question of how to monitor glucose still remains controversial. This one sort of observation that some studies that use glucose meters had higher hypoglycemia and not as good outcomes or negative outcomes than those that used lab methods or arterial blood gas analyzers has raised a lot of speculation about maybe the way you monitor glucose is very important. So why do we care so much about hypoglycemia? Well, a single episode of severe hypoglycemia, it doubles the rate of death in the hospitals. Some note the reference there, Dr. Prinsley from 2007. And so again, sensitivity analysis says that yes, you get some benefit from glycemic control, but you have to do that without increasing hypoglycemia too much, because there's a point where the increase in hypoglycemia will just completely offset any benefit you could get out of glycemic control. And so the question is, again, could the glucose meter inaccuracy or errors or interferences be leading to hypoglycemia and therefore preventing or creating adverse outcomes in glycemic control that you could otherwise avoid with better glucose meter methods or glucose measurement methods? So what are all the variables that impact the effectiveness of glycemic control protocols? Well, there is actually quite a bit of data on this now. And so you look at the major impacts of efficacy of a glycemic control protocol are really going to be related to the target range. How low are you trying to go and how wide is that range? The sophistication of the dosing algorithm. Does an individual nurse or human being have to make a decision after every measurement, and if they forget to do something, then the patient's going to get too much insulin? Is there a system to prompt the measurements and adjustments of insulin? And those are certainly the major factors. Some of my colleagues here at Mayo had done a study now several years ago showing that 90% of hypoglycemic episodes in the ICU were due to this protocol error. Somebody didn't make a glucose measurement when it's due, they didn't act on it correctly. But certainly we worry about the accuracy of glucose monitoring devices. And on the things I'm going to talk about next, interferences, hematocrit effect, medication interferences, overall accuracy are going to be important. I'm going to show you data in a few minutes that shows that just switching the meter did impact the efficacy of the glycemic control protocol at Mayo Clinic. So meters, measuring devices, and their accuracy do play a role, but I don't want to be a message to be that's the only thing to make a glycemic control protocol more effective. There are certainly other variables. So we're going to switch gears now and talk about the technical or technological limitations of meters, what factors influence the relationship between the glucose meter result and the reference. If you say the reference hexokinase plasma is usually the reference in most hospitals. Well, there's this issue of whole capillary blood versus plasma. They have to use a conversion factor. It's affected by hematocrit and red cell volumes and other factors. And some technologies simply do this better than others. There's a great deal of data out there on that. Sample type, so capillary has the limitations of conversion, but also has other technical limitations we'll talk about. But venous catheter blood is also perhaps less desirable, and I'll talk about some studies looking at problems with venous catheter, which has resulted that the probably best consensus, the best sample to use for glycemic control protocols is going to be arterial whole blood, usually from an arterial catheter. And then interferences, medications, oxygen, others, which again, improved technologies in glucose meters have really solved many of the interferences that are out there, but they're not all equal. And so we've published data on vitamin C recently in the last couple of years comparing vitamin C interferences among the major glucose meters, and you will see differences and need to be aware of medication interferences. So capillary versus arterial or venous glucose. We know that the impacts of edema, shock, and tissue perfusion can result in significant outliers where the glucose can be, falsely high or falsely low, leading to inaccurate insulin dose and severe hypoglycemia. I've given a couple of publications related to this in the middle, Khan and Kanji. And so institutions who use capillary sampling in the ICU need to be aware of this and need to have some system to assess if they're going to use capillary sampling in the ICU. Assess the tissue perfusion by capillary refill, by looking at blood pressures. There are several systems out there to do it. It's not clear any of them are it's clear that none of them are entirely effective, but you'll need to do something to make sure you're not using capillary sampling on patients with very poor perfusion. This has been a particular interest of mine. I'm going to show some data on capillary versus venous results and the accuracy of capillary sampling in a minute. But it's interesting that the technological versus the physiological limitations of capillary sampling still remain unknown. And so what I mean by that is some meters are better at eliminating interferences, working with small volumes, avoiding problems when you have a poor capillary sample. But there's a physiological limitation in that sometimes when there's poor perfusion or edema or shock, the glucose concentration in the capillary compartment is simply different than the venous. And even if you got a milliliter of capillary whole blood and made plasma and put it on your lab hexokinase method, the technology is not going to help you. It's a physiologic limitation. And we see that with different devices. Capillary sampling is more or less accurate, so there is a technical component, but we don't know where that kind of line is. How much is physiology you can never overcome, and how much can be overcome with better technology? And that's been a real interest of mine, but again, we really don't have answers at this point. It's a really interesting question to explore in the future. What about venous catheters? And a lot of patients, there's a move to get arterial catheters out earlier. So the easiest way to get a sample might repeat every hour, 2 hours, might be through a venous catheter. Well, I've listed 3 publications that show that venous catheter blood overestimates the true venous reference plasma glucose drawn by a venipuncture and sent to the lab. Some of this is because you give medications and solutions that contain glucose, so there's exogenous glucose in the venous catheter. But that's not the only reason that the venous catheter is a less ideal sample. The publication in the middle, back in 2009, now about 15 years ago, we actually showed that 2 different glucose meter technologies had different levels of bias and interferences with venous catheter whole blood. So there's actually some properties of venous catheter whole blood when the blood sits in that venous catheter. Something changes, the viscosity of the hematocrit, something changes such that the technology you use does matter, and better technologies will allow you to more accurately measure glucose concentration in venous catheter samples. But there are still, and I'm going to show some data on this, going to be some percent of venous catheter samples that are contaminated by exogenous glucose that, again, you can't fix that with technology. So the arterial catheter samples are going to be the best bet. But there's a movement to get arterial catheters out earlier in ICU patients. So the question is, what's the second choice? If you don't have an arterial catheter, do you use a capillary sample or a venous whole blood sample, a venous catheter sample? And I'm going to show some data in a few minutes that suggests that, there may be about equal, or maybe you want to choose arterial or a capillary over a venous catheter. But again, you would have to have a system in place for capillary to avoid sampling in patients with very poor perfusion. All right, so this summarizes kind of the first half of the talk. A lot of things that will lead to errors and outliers with whole blood glucose measurement that can affect glycemic control, that could lead to excess insulin dosing and bad patient outcomes, hypoglycemia, and bad outcomes. The shock and hypotension and edema are really only going to affect capillary sampling. So if you don't use capillary sampling, you don't have to worry about those. If you do, you have to find a system to address those. All these other things, the hematocrit effect, well, alcohol drawing is only capillary sampling. Underdosing strips is more significant with capillary than other forms. The other variables I've listed here will affect all sample types. So again, you need to address all of these in your point of care program to have the best possible outcomes for your glycemic control protocol. And then before I move on, I'm going to show data from Mayo Clinic on what happened when we switched meter technologies, what we got in terms of improved accuracy or reducing total error, allowable error, and then what effect that had on our glycemic control efficacy. But just a brief overview of glucose meter accuracy guidelines. Going back to 2003, we basically said for most glucose values, if you're within 20% of the real value, that's good enough. And now the CLSI point of care 12A3 guidelines from 2013 suggest that no, we really want to be for values above 100 mg per deciliter. 95% of the time, we want to be within 12.5%, or if the values are below 100, within 12 mg per deciliter. And the FDA adopted very similar guidelines. So basically, the guidelines have shifted over now many 15, 20 years from allowing about 20% total error to allowing about 12.5% total error. And the question is, if you do that, first, one question is, are there technologies out there that can hit that 12.5% error? And the second is, if you do that, what will the impact be on patients? And that's what we'll cover in the next few minutes. All right, so this was now some years ago, and we wanted to ask this question: can these newer meter technologies that reduce interferences, that are better calibrated to plasma hexokinase, reduce error when fresh whole blood samples are tested in critically ill patients after cardiovascular surgery? And if so, is it because they reduce the bias relative to a reference measurement, or are they reducing imprecision, or both? So where are we at today with the glucose meter technologies? How did we get there? But do we reduce bias or imprecision? And then the second question, which of course is more important but harder to address, much harder to address, if you can hit this 12.5% total error with glucose meter measurements because you reduce bias or imprecision, doesn't matter. Will the efficacy or outcomes of your glycemic control protocol in the hospital actually change? All right, so now this is going back about a little over 10 years to a study we did, and we moved from the Accucheck 1, which is an older, Accucheck Inform 1, which is an older meter technology, to the StatStrip around that time. And so we went back and we said, what was the effect on the accuracy and precision of glucose measurements by replacing an older technology that didn't have interference correction, that wasn't as well calibrated to plasma hexokinase, on accuracy and precision. So we looked at accuracy by doing a retrospective study of patients who had cardiovascular surgery before and after we replaced the meters in our cardiovascular surgery ICU. And we looked at precision with fresh whole blood done at the bedside. And I've published a lot of glucose meter and others. There's dozens and dozens of publications. Precision studies are usually done running controls or serum samples repeatedly, but that's not precision at the bedside. There's very little published on, well, if you actually dose somebody's meter 5 times with 5 different blood samples at the bedside, what precision would you get? So we did that first, and we didn't do many patients. We did 20 patients, 5 measurements at the bedside with each patient, 100 measurements total, and we used these repeated 5 times over 20 patients, designed to calculate coefficient of variation. And of course, the limitation is that you can only do it at one sort of average glucose concentration of the 20 patients. So it was around 140 mg per deciliter with both devices. But we found the coefficient of variation was similar. So 2% with the Inform 1, 2.7% with the StatStrip. So it seemed like precision didn't change. The actual precision at the bedside wasn't the limitation. Both precisions were under 5% CV, very good at a relatively normal glucose level. And the 2 technologies didn't differ much in precision observed at the bedside. So what about accuracy? Again, this was a retrospective part of the study over 3 months. We had 1,600 paired Inform whole blood glucose measurements done within 5 minutes of drawing a sample for a lab serum hexokinase. And then after we implemented the StatStrip, 1,000 or about almost 1,100 paired StatStrip samples again, the StatStrip done within 5 minutes of a specimen sent to the lab for serum hexokinase glucose. So this is a Bland-Altman plot of the Inform 1, the older technology. The median bias was 11 mg per deciliter. So on average, the meter was running significantly higher than the reference method. You can see the spread of results. Most results are somewhere between negative 10 mg per deciliter to about positive 20 mg per deciliter. So there's a pretty wide range and a significant positive bias, about a 9% positive bias with the old technology. And these are the results with the StatStrip, 1,100 samples. You can see the median bias almost 0, 1 mg per deciliter, and median percent bias 1%. You can see almost the vast majority of results somewhere between about negative 10 and positive 10 mg per deciliter. So the vast majority of results are plus or minus 10 mg per deciliter instead of having results distributed on a positive, skewed to a positive bias and distributed over a much wider range with the older technology that did not have interference and hematocrit detection and correction. So here's the bottom line. Total allowable error can be viewed as percent of results within either 10, 20%, or 12.5%, or 12 mg per deciliter, the CLSI, point of care 12A3 guidelines. So the older technology we saw that about 92% of results were within 20% of the lab. So didn't even quite meet the 20% total error definition. And with the StatStrip, we hit just exactly 95% of results within the CLSI guidelines. So we managed basically, what did we gain from replacing an older technology with interferences to the StatStrip that had Hematocrit and interference correction that was better calibrated? The plasma hexokinase, well, we went from just over 20% total error to just 12.5%. So the answer was yes, that StatStrip can meet the error guidelines. That was our study. I should mention that NOVA did support a much larger study published 2017, a 5 sites international study, also having prospective paired glucose measurements, and found the same thing. Basically 96% met the CLSI guidelines. So essentially, yes, in this large prospective study, they hit the 12.5% total error. They did error grid analysis to look at significance of errors, and the errors that were there, outliers were there, and the errors were not very rarely clinically significant. And give you the reference. So again, our study and this large prospective study published and supported by NOVA at 5 centers shows that yes, you can hit 12.5% total error with the device. So now the question becomes, okay, great. You can use newer methods, and the StatStrip is one of them, to reduce error, have more accurate glucose measurements in your ICU. And the question is, well, so what? If we go back to the very beginning, the Vandenberg, Louvain 1, Louvain 2, nice sugar, et cetera, studies, what you really like to know is, well, is that going to affect ICU mortality and morbidity? Are you going to have fewer wound infections or renal failure? Those studies require thousands of patients moved into control and intervention arms, and are very difficult, time-consuming to do. And to my knowledge, no one's done one just where the only variable is the glucose monitor, and to see if that has an impact. You can do something that moves in that direction, though, by looking at glycemic control efficacy. So glycemic control efficacy is a well-defined concept. It involves glycemic variability. How much does the glucose change if you're trying to hit one range? How much does the glucose change measured by standard measures like standard deviation, or I'll give some other glycemic variability standard measures. The time within the target range, right? So does a better glucose meter or monitor allow you to spend more time in the target range in the ICU? And the incidence of hyperglycemia and hypoglycemia. And so you can do that, it turns out. You can power that, and we formally powered our study, and there's been only one other study I'm aware of. 2 studies basically have looked at specifically, does the glucose meter affect glycemic control efficacy? You can power those with about somewhere between 75 and 150 patients total. And so that's what we did. Again, why measure efficacy? Well, because what you want to know is outcome, but that's very hard to do. But it's reasonable to know that, to assume that more hypoglycemia would lead to bad outcomes. More hyperglycemia would also lead to bad outcomes. That's the whole basis of the studies, is that hyperglycemia leads to worse outcomes after cardiovascular surgery and in the ICU in general. And glycemic variability alone is sort of bad. More variability is going to mean more hypo and hyperglycemia. And there's an emerging literature and field that suggests that just having more variability in glucose levels in the ICU alone may decrease survival. And so what we wanted to know basically is, can reducing meter error, we know we went from over 20% total error to 12.5%, did that alone improve glycemic control efficacy? So again, given that we changed in around 2012 from a method that meter that had about 20% total error to 12.5% total error, could we find through retrospective analysis that it made a difference on glycemic control efficacy? So we did a study, originally another retrospective study, where we looked at patients in the cardiovascular ICU who were placed on the glycemic control protocol in place at the time. And we looked retrospectively to enroll patients, 70 patients who were monitored by the previous AccuCheck Inform 1 method, and another 70 patients who were monitored with a StatStrip, who all the enrollment criteria is they had 12 to 24 consecutive glucose values performed while on an insulin drip. So they had 12 to 24 occasions where there was going to be a glucose measurement and an insulin dose adjustment related to that measurement. As far as we knew, there were no changes in the infusion protocol and the testing personnel and the way the protocol ran during that period. So it was a retrospective study between 2 periods of time where, as far as we know, the only variable that changed was the glucose meter we used to measure glucose to change the insulin drip on our insulin infusion protocol at the time. So the outcomes were glycemic variability as measured by standard deviation. And I think you all probably appreciate what a standard deviation is, a measure of variability around the mean glucose in those 12 to 24 measurements per patient. There's another related, it's kind of related to standard deviation, commonly used measure of variability for short periods of time is the continuous overall net glycemic action, or CONGA. And then we also obviously looked at the percent values in the target range. The target range at the time was 110 to 150. It was what you call a moderate glycemic control protocol. And incidences of hypoglycemia and hyperglycemia. And we know going in that we didn't have much hypoglycemia in our ICU, but cardiovascular ICU, but we wanted to look at incidence of hypo and hyperglycemia. So this just shows the patient characteristics in the 2 time periods. Mean age didn't differ in the 70 patients monitored with the Inform 1 versus the StatStrip. The gender distribution was similar. In both time periods, I intentionally selected half the patients who did not have diabetes, ND is no diabetes diagnosis, and half who had a diagnosis of type 2 diabetes. Because I wanted to see whether, if the meter accuracy made a difference, was it more significant for patients with diabetes type 2 who are commonly have cardiovascular surgery, or non-diabetic patients, or both. And then you can see the median number of measures, glucose measures, and therefore insulin adjustments per patient was similar, 22 versus 21. So we had these patients getting on average 21 or 22 glucose measurements, 21 or 22 insulin adjustments, and we wanted to know, does the meter accuracy impact the efficacy of glycemic control? So this is the overall results. You can see the median glucose actually was slightly lower in period 2. So that was just an observation. We didn't expect that, but actually there was a change in median glucose level among these patients with the StatStrip more accurate technology. What we did expect to see was the variability go down, measured by standard deviation, or CONGA, and we did see that. You can see the median standard deviation was 21 micrograms per deciliter, and I give the interquartile ranges there, and decreased to 13.7. So using the more accurate meter decreased the variability, and then the CONGA, similar measures, went from 19.4 to 13.5 mg per deciliter. So we reduced variability, but did we increase the time in the target range? And the answer is yes. The time in target range for the overall 70 patients pre and post of the old meter and the improved meter technology increased from 66.7% time in target range to 74.5%. So that was evidence, and again, it's retrospective with a snapshot of 2 groups, but evidence that in a period of time where, as far as we know, the only variable changed was the accuracy of the meter we used to measure glucose, that it did have effect on glucose variability and time in target range. Then we broke this out. We wanted to look at the effects in non-diabetic patients, the 35 non-diabetics versus the diabetic patients. You can see the effects in non-diabetic patients weren't as great. So the glycemic variability measured by standard deviation and CONGA did decrease by about 20%, which was statistically significant. But the time in target range did not change significantly for non-diabetic patients. If you look at patients with type 2 diabetes, 35 of them in each by design, 35 patients with type 2 diabetes in each cohort, there was a 40% decrease in glycemic variability between the period 1 with the older method, less accurate method, and period 2 with the StatStrip, and a very large impact in time and target range from almost 62% to in 78%. So again, the largest effect we saw was in patients with type 2 diabetes. There was an overall effect on the whole population, as well as an effect on glycemic variability in non-diabetic patients. So again, the data shows that switching glucose meter methods to a more accurate method, reducing total allowable error to under that 12.5% recommended in guidelines, seems to have affected both the glycemic variability and the time and target range for this 140 patients, 70 pre and 70 post, where we switched to a more accurate meter, and seems to have a bigger effect among patients with type 2 diabetes. What about hypoglycemia? Well, we know we didn't have much hypoglycemia even before we switched meters. So again, there was a single episode of hypoglycemia in period 1, none in period 2. But you can see the episodes of hyperglycemia, defined as glucose over 200 mg per deciliter, did decrease quite a bit, from 26 episodes or patients in period 1 to only 6 in period 2. So we actually saw reducing variability, increasing time and target range, decreased hyperglycemia. So it's not an outcome study, it's not mortality, morbidity, but it's a reason to believe that you may see outcome effects. And everybody who's been in academics long enough has that one study you think, gee, nobody talks about this. This is really important. Obviously, outcome is important, not just measuring, lab experiments, measuring the accuracy of meter A versus B. So I have given you the reference here because it's basically one of 2 studies that actually showed some outcome effects related to glucose meter accuracy in the context of hospital glycemic control. All right, so summary: newer glucose meter technologies reduce error of measurement at the bedside when used on critically ill patients. And there's evidence emerging that improving that accuracy and performance, basically reducing error, will improve the efficacy of glycemic control, and reasonable to believe that that may improve patient outcomes in the ICU. Maybe someday myself or someone else will do that 2,000 or 3,000 patient outcome study, but until then, what we have are a handful of studies or a few studies looking at glycemic control efficacy. All right, I'm going to finish up 5 minutes or so talking about capillary sampling in the ICU. Again, a lot of concerns about the accuracy of capillary sampling. As I mentioned a little earlier, if you can have arterial whole blood, use it. But if you don't, should you try capillary sampling? Should you sample from a venous catheter? How good is capillary sampling? All right, so this is unpublished data that I have presented a few times publicly, so it's not a secret, but it is not yet published in peer-reviewed journals, so be aware of that. We looked, and basically this was Nova Diagnostics working with Mayo Clinic and Johns Hopkins, Bayview, Johns Hopkins, to do these studies. We looked at pooled retrospective and prospective capillary glucose accuracy data to understand how good can we get with capillary blood. Can we hit the CLSI guidelines, which we showed we can hit with arterial or venous whole blood? Can those be met using capillary whole blood? The study had 568 prospectively collected paired capillary glucose meter and reference glucose measurements. 368 of those paired measurements were from a previously published study performed in the operating room here at Mayo Clinic, published in anesthesiology now several years ago. 200 were from a prospective unpublished study in the Mayo Clinic ICU. So that's the unpublished piece of that data. Part of that are those 200 prospective samples done in the Mayo Clinic ICU. And we had, on the prospective cohort, we had a lot of information to look at medications and blood pressures and temperatures and capillary refill to understand, could we predict capillary outliers, which again, I kind of gave away. You can try, but there's no system that'll predict them all, which is one of the risks of capillary blood. The retrospective, so retrospective mean we went back and looked at paired capillary and lab reference measurements done within 15 minutes of each other, came in, this is also unpublished data from Johns Hopkins Bayview, a very large retrospective data set, almost 15,000, and another 2,000 retrospective data points from Mayo Clinic. So what I did is I pulled this data and I said, well, it's hard to get an answer of how good is capillary sampling, There are a lot of retrospective studies out there, but they're all difficult to interpret because we know that some amount of venous whole blood samples are going to have exogenous glucose contamination. And they're going to look like outliers where there's a huge difference between the glucose meter and the lab reference. And in those cases, the lab reference is likely wrong. But if we compare the accuracy of the pooled prospective data, where you're being observed during a prospective study, so the chances of contamination are much less, maybe we can get to sort of an idea of what's the ceiling on performance of this particular meter. This is all data with a StatStrip with capillary whole blood. The retrospective data sets in the studies were handled a little bit differently. Bayview Hopkins had a larger data set and didn't filter. In the Mayo Clinic data set, we did filter, where we went in when there are large discrepancies between the lab reference value and the meter. We went to look for subsequent measurements that would suggest a contamination pattern. We have a middleware system that flags suggested contamination, and those suggested contamination samples were removed from the Mayo set. No samples were removed from the Bayview set, so there were very likely contaminated samples in that sample set. And here's the bottom line. So in the answer, in one of the ways I'm trying to get my hands around, well, what's the ceiling on capillary blood, is that we have a smaller prospective data set where we're not so worried about having contaminated reference lab samples and being a cause of outliers, and a much larger, that's 568 prospective samples pooled together, and a much larger, almost 17,000 samples in retrospective, where we know some of those are going to have contamination. But if you look at the percent within 10%, percent within 12%, or 12 mg per deciliter, or 12%, or the percent within 15 or 20%, the percent within 15% or outliers defined as differing by 20% or more than 20 mg per deciliter, the prospective and retrospective data sets are really lining up together. And so we can likely conclude that, whether you're looking at large retrospective data sets that have this issue of how to weed out contaminated samples, or prospective data where you're not as worried about it, it doesn't appear that using capillary sampling that you can meet the CLSI POCT12A3 guidelines to hit that 95% of samples within 12.5% or 12 mg per deciliter below 100. Looks like you might hit somewhere in the 85 to 87% range, but not yet to 95%. Then we did Park's error grid analysis to look at, okay, in the prospective, and this is separating out the two prospective studies where we're not as worried about contaminated, how significant were the errors? And you can see that in error grids, have zones A and B are really consistent, no change in insulin dose. Zones C, D, and E, you get to progressively more dangerous insulin dosing errors. We had a single zone C sample, so rarely, only one of 568 samples would have a significant effect on insulin dosing in the context of subcutaneous insulin in the prospective errors data set. In the retrospective error data set, again, we separated out to the Mayo data, which had been filtered for contamination, where we saw very few C, D, and E, or at least saw one zone C again, and similar to the prospective. But the Hopkins data set, which is unfiltered, you see there's significantly more. So there were about 0.2% of all results were in zone C, and rare zone D and zone E results as well. So we also did outlier analysis on the prospective to say, of those 4 outliers from the prospective side from Mayo, there were 4 outliers that hit the over 20% difference, or 20 mg per deciliter. What was the cause of them? Because the study design, we actually did duplicate capillary samples. So if it was a poor capillary sample, you look at a difference in duplicate. If you have simply both capillary measurements were fundamentally different from the lab reference value, that can be categorized as a physiological difference. And so what we saw were there were 2 of the 4 that likely that capillary concentration of glucose was different than the venous, and you can never fix that with a better meter. One of them, the 2 capillary measurements were discrepant. So that's a technical thing where if you get a better sample, you might fix that. And one of them likely had reference lab contamination. So even in a prospective study, you can never eliminate that. In terms of can you predict them with the usual methods often used, capillary refill, warm finger, blood flow? Well, most of these outliers had sort of normal capillary refill and acceptable blood flow as judged by the performing nurse doing the measurement. So again, you can try to catch these outliers by looking at perfusion and capillary refill, but it's not as easy as you might think. All right, the last thing I'll present, we wanted to know, back to the question, if you have a choice of capillary or venous whole blood, which should you use? So we have a system where we track and we flag contaminated samples. That's how we filtered our capillary retrospective data set. So I did a very kind of shirt sleeve calculation. This is not highly elegant, where we estimated in a period of time, we had about 30,000 venous line samples received in the lab, and about 32 of those were flagged as contamination suspected by our middleware. So that comes out to about 0.1% of all venous line samples are contaminated with exogenous glucose. And if you look at the rate of outliers from capillary blood from our prospective and retrospective studies, the rate of those clinically significant zone C through E outliers are somewhere between 0.05 and 0.2%. So the rate of outliers in capillary blood and the rate of contaminated samples from a venous line are about the same. And I suggest probably the rate is higher of venous line contaminated samples than capillary outliers. So in terms of the second best choice, it's a tough one, because if you have a good way to screen the patients to avoid capillary sampling when they're poor perfusion, you may be better off doing that than having to have a system to detect contaminated samples. You can use venous lines for glucose meters if you have a good system to detect contaminated samples. That's hard to do at the bedside. Our system relies on the central lab middleware rules, not at the bedside. So in conclusion, newer meter technologies have reduced error measurement in glucose in critically ill patients. So can we meet the CLSI and FDA guidelines with arterial whole blood? Yes, we can. We probably can't with capillary whole blood. There is evidence that improved glucose meter accuracy results in increased glycemic control efficacy in the cardiovascular ICU, the study that I presented. You are going to see more outliers when you use capillary whole blood compared to arterial whole blood. And again, it doesn't appear that the FDA or POCT12A3 guidelines can be met using all capillary samples. The rate of outliers is about 3% with capillary whole blood, but only between 0.05 and 0.2% of those will be clinically significant as you judge by the Parkes error grid effects of the significance of an insulin dosing error. And you need to judge the rate of contaminated venous line draws versus the outlier rate of capillary samples. And I think this is a really, to me, interesting area for future research, which is the best second choice, a capillary sample or a venous line sample. And it may clearly vary locally. The rate of contaminated venous lines is probably going to vary by nursing and other practices within your institution. So with that, I just want to acknowledge many people who did many of these studies, my colleagues, Dr. Donato and Dr. Curry at Mayo Clinic, Gail Diebold, Amy Wokenfuss at Mayo, Doctors Bill Clark and Matt Olson at Johns Hopkins, and Jeff Dubois, Martha Lyon, Andrew Lyon, Jeff with NOVA, and did some of the statistical analysis. And with that, thank you for listening today. I'm going to turn the program back over to Rick.
Thank you, Dr. Karon. The evidence certainly points to less glycemic variability, better time in target range, and improved outcomes with improved glucose meter accuracy. Now we'll hear from Dr. Naveen Bangia to discuss the clinical importance of blood ketone testing in adult and pediatric critical care patients. Naveen?
Thanks, Rick. I wanted to follow up today on Dr. Karon's excellent presentation in the critical care space to point-of-care testing of glucose and ketones, so kind of more focusing on the new next-generation ketone meter in the hospital setting and its clinical value. So as mentioned, controlling glucose in hospital settings is important in many departments. So you heard a lot about the intensive care setting just now from Dr. Karon. What I'm going to talk a little bit more about is the ketone measures, more in the emergency and trauma units, and also a little bit in the ICU. So blood glucose testing has two options really in generally speaking. That's the central lab over here on the right, the large central lab instrument where the blood, plasma, or serum gets sent off to measure glucose. Or on the left, you see a variety of handheld meters that really just require a finger prick. And these are very easy to use, very fast results, allowing clinical decision making. And these are the point of care devices, as I mentioned. So near patient testing. So in terms of blood glucose, the consequences of blood glucose is some of the symptoms shown here: being very tired, excessive urination, excessive thirst, for example. And this the high blood glucose levels leads to damage to small blood vessels, leading to things like blurry vision, renal impairment, and nerve damage, which is tingling in the hands and feet for those symptoms. You can get dehydration with this high blood glucose, and as I mentioned, excessive thirst. So diabetes, actually, the word comes from the Greek word for flow through, and that's what the early physicians called it, based on the excessive thirst and excessive urination. So it's as if this disease was causing excessive flowing through of the fluids. So in terms of our standard blood glucose measures, you can see the fasting levels here in millimolar. In green there, 3.9 to 6.1 is the normal range. Above that in the orange is the pre-diabetic range, up to 7 millimolar, and then above that is diabetic, so high levels. And in the glucose tolerance test, for example, the cutoffs here are 7.8 millimolar. That defines above that as pre-diabetes. And the definition also of diabetes is also incorporating hemoglobin A1C if it's greater than 6.5%. So what is diabetes exactly? When we think about our eating cycle and what occurs to maintain our blood glucose levels in the appropriate range, it's kind of shown here on the far left. Is when you get a meal, the blood glucose increases. That leads to your pancreas responding with insulin production, which allows cells to take up the glucose, so cells in your muscle, for example. So it takes up the glucose from the blood and gets stored. The liver also takes it up as glycogen, stores it as glycogen, and gluconeogenesis goes down. So then that brings the blood levels of glucose down. That uptake by the muscles, for example, and the uptake by the liver to store as glycogen brings our blood glucose levels down to that normal range of 4 to 6 millimolar, for example. At night, for example, when the blood glucose is dropping, when we're fasting, not eating, you have glucagon produced by the pancreas, and then that leads to, instead of glycogenesis, you have glycogenolysis. So you've got break apart of glycogen to glucose, and glucose is produced. So that allows glucose to be produced by the liver, released into the blood, and that brings our blood levels back up to normal. So again, looking at these definitions, the cutoffs for diabetes, you can see the normal ranges in milligrams per deciliter from 70 to 140 or so, and 3.9 to 7.8. But above 11.1 millimolar is really hyperglycemia, and when it's done, that's in general at any time blood glucose up there. The fasting levels, though, here are shown here. A fasting level of glucose needs to be below 7.0 millimolar. And in the glucose tolerance test, it should stay below 11.1 millimolar to avoid the diagnosis of diabetes. So diabetes is actually this disorder, as we talked about. There's two types. Type 1, which is an autoimmune type of diabetes, where the CD8 positive T cells are part of our immune system that kill off the pancreatic beta cells that produce insulin. And so insulin cannot be produced after a meal, for example. That means that the glucose can't be taken up by the muscles, and glucose can't be stored in the liver. So it just stays in the blood, and the blood glucose levels do not come down, they stay high. So that leads to that high blood glucose, as I mentioned, at those cutoff levels to diagnose diabetes. So the treatment here, though, is fairly straightforward. Is insulin. So because the body doesn't have insulin in these individuals, because it's been the cells that produce it have been killed. We're just adding. They're just treated with insulin, and that manages to bring their blood glucose back to appropriate levels. It's a matter of timing and amounts of blood glucose is very important as well here in this treatment. So in type 2 diabetes, however, it's a little bit different scenario, and that is there's plenty of insulin in folks with type 2 diabetes. In fact, it's usually in excess because the cells that are supposed to respond to insulin to take up glucose are resistant. So glucose still doesn't get taken up, even though there's insulin, because the cells themselves are resistant, and you don't get take up in the liver as well. Again, the end result is still high blood glucose, leading to all those symptoms of polydipsia, polyuria, for example. And so the treatment here, though, is really lifestyle and diet, in the sense that this comes from excessive eating, not enough exercise, and so on, and part of our lifestyle that we have, which is highly sedentary these days. So coming to that point of the metabolic syndrome, so diabetes doesn't exist in a bubble. It actually kind of coexists quite a bit with these other disorders, things like heart disease, lipid issues, hypertension, and things like non-alcoholic fatty liver disease, all are associated with this round belly and sedentary lifestyle. So metabolic syndrome is really any three of these five things. One is abdominal obesity, shown here as number one. And that can lead to things like free fatty acids, also cytokines being produced. Cytokines leads to vasoconstriction, which leads to higher blood pressure. So that's one of the elements. Two is blood pressure, elevated blood pressure. It also impacts the pancreas and insulin production. So you get insulin resistance, and so your fasting plasma glucose levels are high. So they're either pre-diabetic or not diabetic, for example. But insulin resistance is another one of these features. And the last two are, associated with the free fatty acids and elevated glucose that impact the liver. That leads to elevated triglycerides and low HDL. So these two elements, again, are part of the five. So any three of these of the five provides the definition of metabolic syndrome, and they all often coexist, as I mentioned, based on our diet and our sedentary lifestyle. So coming back to, so we've talked a lot about blood glucose, as I mentioned, where, you've got high blood glucose in this case of type 1 diabetes because the insulin's not produced, the cells are being killed off. However, the cells themselves are starved of glucose because they can't take up that glucose. So what occurs in that situation? Cells that are starved for glucose actually find alternative energy sources. And those cells that are starved for glucose then use fat. They break down fat into fatty acids and glycerol. The glycerol can be converted to glucose in the liver, and the fatty acids can be converted to ketones. And those ketones, that's this process of ketogenesis, will then get produced and released into the blood. So you've got ketones produced and released into the blood. And so we have this situation of high blood glucose. The ketones are released, and that the blood also becomes acidic. So this is really what I'm defining as diabetic ketoacidosis if it goes too far. And so the diabetes is from the elevated glucose. The acidosis comes from the low blood pH, and then it's also the detection of ketones in the blood. So these ketone bodies can be acetic acid, beta-hydroxybutyrate, or acetone. And these three features are what define diabetic ketoacidosis. And it's really beta-hydroxybutyrate that is the major or predominant ketone that's produced. And that's what I'm going to spend some time talking about now, is the value of detecting these ketones, the beta-hydroxybutyrate in the blood, as opposed to things like looking at urine, acetoacetic acid, for example, which is a later term molecule, and also slower to clear. So it actually impacts the resolution or the apparent resolution of diabetic ketoacidosis. So that's what I'm showing right here is the ketone bodies are, go to the brain and they're involved in neuroprotection. But the ketones in the bloodstream get metabolized by muscles and produce acetoacetate or acetoacetic acid. And so this is kind of what a diagrammatic look at what the timeline looks like as a patient is increasing their blood beta-hydroxybutyrate here in red. It'll resolve over some time after treatment, for example. However, the acetoacetate that's observed in the urine after metabolism by the muscles is a delayed event. You can see it comes up slower, it's lower, and it resolves later. So if you have this situation when the ketone production is actually stopping, then the ketones in the bloodstream decrease, but the acetoacetate continues to rise. So what does that mean? When you look at this graph, what we're talking about is this time frame where the ketones are resolving. They're on the way down, but you can see the urine acetoacetate is continuing to rise in this shaded region. And what that means clinically is when you're looking at a patient and their urine acetoacetate may be increasing, you think there's still active process going on and active disease and the patient is getting worse. When in fact, the blood beta-hydroxybutyrate in this shaded region is actually going down. So the blood is a more accurate measure of what's actually going on with the patient. And that allows, as I'll show you in a few minutes, patients to be released sooner from the ICU, for example, because when they're monitored by the blood beta-hydroxybutyrate, it's clear earlier that you can see a decrease in the resolution of the ketosis, decrease in the ketones. So diabetic ketoacidosis has a huge impact on our society. Of type 1 diabetes patients, the 25 to 30% of them present in diabetic ketoacidosis. In the case of type 2 diabetes, those patients also present, and 4 to 29% of them, usually children, present in this way. And that's because this is before they're diagnosed with diabetes, right? So that's the situation where you get these folks ending up in the ER with severe symptoms like nausea, vomiting. So this study was actually a 10-year analysis of from 2003 to 2014, looking at 1.76 million primary admissions with 7,031 deaths. So what's the burden on the healthcare system? You can see that there's almost 200,000 diabetic ketoacidosis cases in 2014 compared to just over 120,000 or so in 2003. The cost per patient has gone up dramatically. 2014, up over $25,000 per patient. But the national bill has more than doubled, up over almost 5.2 billion compared to just over 2 billion in 2003. The mortality rate has gone down, and I guess that also means that we're managing it better. So from 0.5% to 0.3% in 2014. So coming back to the hospital settings and the various places where you think of measuring glucose and measuring ketones for diabetic ketoacidosis, the diabetes clinic is obvious, but I'm going to focus a little bit on the emergency room now and how these patients present. So patients may come in with fatigue and nausea, vomiting, and things like that. And looking at what is diabetic ketoacidosis, it's really when plasma glucose is greater than 14 millimolar. And this can be lower if the patient is on SGLT2 inhibitors or there's pregnancy. But typically, plasma glucose greater than 14 millimoles. The pH is less than 7.3, and then so that's the acid part, and then the ketones can be measured either in serum and or urine, with beta-hydroxybutyrate being one of the blood measures. Serum bicarbonate less than 15 millimolar and anion gap greater than 12 millimolar. And in this study, when they looked at this with 111 consecutive patients, they measured their blood glucose if they had a history of diabetes, These are patients that presented in the emergency room over a 3-month period. They had they measured blood glucose, as I mentioned, if they had a history of diabetes, they had current or past use of hypoglycemic agents or insulin, and if they had a presenting symptom of hyperuria or polydipsia, so excessive urination or excessive thirst. And when they measured blood, the beta-hydroxybutyrate, they had a cutoff of 3.5 millimolar that gave them 100% sensitivity, 100% specificity, 100% positive predictive value, and 100% negative predictive value. So a very useful tool in the emergency room was using point-of-care beta-hydroxybutyrate. And this is supported by another study that was retrospective, and a quote from the authors was that diabetic ketoacidosis was more accurately predicted by quantitative determination of 3-hydroxybutyrate or beta-hydroxybutyrate than by urine dipstick analysis of acetoacetate. So that's really the comparison. If urine dipstick analysis is being used, it seems that the blood ketones are earlier, faster, and more accurately predict the diabetic ketoacidosis. When we think about another study here, 479 known patients with diabetes or newly diagnosed diabetes. These are non-trauma victims. And from the ER, their finger stick glucose was greater than 200 mg per deciliter. If that's the case, then they had the beta-hydroxybutyrate measured. And if they had a greater than 0.1 millimolar beta-hydroxybutyrate, then they were included in the study, and all of these measures were done. Capillary, venous beta-hydroxybutyrate, venous blood glucose, arterial blood gases to look at acidosis, and urine dipstick. And what I'm showing on the right side here is really the sensitivity and specificity of the urine versus capillary measures for diabetic ketoacidosis on the left half of the graph, and on the right is the urine versus capillary looking at hyperketonemia. And you can see the sensitivity for urine is 66% compared to 72% for the point-of-care beta-hydroxybutyrate. So again, beta-hydroxybutyrate has a higher sensitivity and also a higher specificity, going from urine at 78 to 82% in blood beta-hydroxybutyrate, measuring diabetic ketoacidosis. So that's including the acid measure. However, and the same is true for hyperketonemia, again, where the sensitivity is elevated when using the capillary measure of beta-hydroxybutyrate, as is the specificity. In a pediatric setting, looking in the ICU, for example, this was one study from Vanelli et al. So they were looking at 33 patients which were randomized to either be monitored by blood beta-hydroxybutyrate or measured by the ketones in the urine, acetoacetate. And what they found was the patients that were monitored by blood beta-hydroxybutyrate showed a 5.8-hour faster decrease in ketone levels compared to urine. So that, again, is because of that metabolism that it takes for acetoacetate to appear in the urine. It's slower. It takes longer for it to decrease. And so the resolved ketosis is actually observed 4.6 hours earlier when measuring blood than in urine. And these patients ended up leaving the ICU even earlier than those who were monitored by urine measures. And the resulting cost savings was for lab and for clinical assessment. You can see 29.8% and 70% respectively. In another study, they looked at also pediatric patients and looking at their endpoint for intravenous insulin therapy. And if the patients were monitored with the blood beta-hydroxybutyrate, they noticed the decrease and they reached the endpoint for insulin therapy. So they could stop therapy in 17 hours compared to 28 hours for patients that were monitored by urine ketone testing. So quite a dramatic difference, again, owing to the fact that the beta-hydroxybutyrate is the predominant ketone, so it rises faster and it resolves quicker than the urine measures. So the Nova Biomedical now has a glucose ketone meter. So one handheld meter that measures both glucose and ketone. Standard strip technology that's known for Nova Biomedical and its interference-free glucose testing. You can get results in 10 seconds. It's only 1.2 microliters and it has full connectivity. So the handheld meter now that's used for glucose can be used for both glucose and ketones, making it very efficient. The only difference is the strips. So how does that compare to the hexokinase, so the manual method, for example? That's shown here. This is the StatStrip, the Nova StatStrip meters. You can see there's really a very good correlation here. StatStrips 1 and 2 of 48 samples. The slope is almost right on 1.0, 0.99, 0.970. The intercept is close to 0, and the R-squared is a really good fit, 0.971, 0.977. Other strips, other ketones meters don't fit as well. They don't match the line of unity here as well, so there seems to be a bias. And as I mentioned, Nova is known for their interference-free glucose testing. Has helped save lives in many hospital settings to avoid that hypoglycemia that occurs when insulin is given unnecessarily, or if insulin or glucose is not given when it's needed. Again, Nova is when manufacturing, always looking to engineer errors out of their testing. This is the ketone meter, and showing the hematocrit interference or lack thereof in the case of the StatStrip, shown here in black solid boxes and open boxes. You can see that for some of the other meters here, as the hematocrit increases, looking at the ketones here, as hematocrit increases, you can see the ketone measure drops dramatically. But that's not the case here for the StatStrip lines. They're relatively flat across different hematocrits, and this is measured at 3 different concentrations of ketones. And again, the same is true for the glucose measurements here, showing what's been shown for multiple years now in the glucose testing, point of care testing. So with that, I'll close with just summarizing that both blood glucose and ketone measurements are critical tests in the ICU and the emergency departments, as you heard from Dr. Karon. And some of the things I talked about were really about diabetic ketoacidosis. Its dramatic impact on not only the health of patients and their survival, but also on the economic burden on the healthcare system. There are several guidelines that recommend blood beta-hydroxybutyrate measurement over urine measures for ketones. That includes the UK guidelines, American Diabetes Association, and the Canadian guidelines. As I mentioned, as I covered, blood beta-hydroxybutyrate measures help lead to better patient outcomes, earlier release from ICU, for example. And cost savings as well, and the methodology used by the Nova Biomedical glucose ketone meter for ketone measurement correlates well with reference methodology and has minimal interference with hematocrit. And with that, I'll close and send it back to Rick.
Thank you, Naveen. Now, before we begin the question and answer session, I want to remind you to submit questions for Dr. Karon and Dr. Bangia using the Q&A tab on your screen. Also, as a reminder, your continuing education certificates will be emailed once you complete a post-webinar survey. A link will be sent to you at the conclusion of this session. Now let's go back to Naveen for the question and answer session.
Great, thank you, Rick. So our first question about the procedure at Mayo Clinic, and the question is, what is the procedure at Mayo Clinic when a critically high blood glucose measurement is obtained?
Yeah, sure. So I think we're probably consistent with many hospital practices in that we do like to confirm a critical high over 400 mg per deciliter glucose meter result with a stat plasma glucose. And we try to do that before dosing large amounts of insulin that may be in response to that critical. But on the low end for hypoglycemia, because I talked about the harms of hypoglycemia in the hospital and the fact that glucose or dextrose as a benign treatment, we don't confirm critically low glucoses. We just treat and repeat. And then if there's suspicion of a glucose meter problem, they'll send a specimen to the lab. But basically, we do stat plasma glucose confirmation of critical high, but not critical low glucose at the bedside.
Thanks for that insight, Dr. Karon. That's great. Our second question is about the variability with hypo and hyperglycemia, and both of them are associated with poor outcomes. So the question is, it's clear with hypoglycemia that it can cause starvation biologically, why that's associated with poor outcomes, for example, not enough blood glucose to the brain, etc. However, it's unclear why hyperglycemia is associated with poor outcomes. Can you comment on the biological mechanisms that might be relevant there?
Yeah, so there is a lot of basic science behind this. Some of it is animal models, some of it is human, but there does seem to be immunologic changes that happen. There's changes in protein expression and cellular metabolism and expression of various proteins in response to persistently high glucose. And there's even data that variability actually in glucose going up and down over short periods of time also may trigger cellular effects. So there is some biology behind it. I think certainly, very high glucose uncontrolled can lead to hyperesmolar coma and immediate bad outcomes. But even just having persistent hyperglycemia over, that 200 mg per deciliter range is thought to trigger immune modulation and susceptibility to infections that has driven a lot of the desire to have glycemic control in the hospital.
Thank you, Dr. Karon. That's interesting insight and still a lot to be uncovered, I guess. The third question is about the differences between capillary and venous catheter measurements, for example, and you mentioned that differences in perfusion can cause some of these observed differences in measurements. The question is whether there can be other analytes that can be measured to control for perfusion, other small molecules, for example, that can tell you about perfusion differences to control for those changes in blood glucose in those two different sites.
Yeah, I'm not aware of any. It's a great question. I mean, the major one that's been studied is glucose. And so we know that the glucose in the capillary compartment under these conditions of very poor perfusion will differ from the glucose in the venous. You would assume that the same would be true for other analytes and that maybe you could use them as some sort of control, but I'm not aware of any data showing that that works or that somebody's tried it.
Interesting. Okay. So most of the studies you mentioned are in the CVICU, and the next question is about whether those data can be extended to all ICUs, medical ICUs, surgical ICUs, for example. Yeah, if you could comment on that.
Yeah, I think it would. Again, so the older studies from 2012, the retrospective accuracy study was all cardiovascular ICU. The glycemic efficacy was all cardiovascular ICU as well. It was basically they had more patients on long-term glycemic control, so we could recruit those 12 to 24-hour consecutive. Often in the medical and other ICUs, we just don't do glycemic control as long, so it would have been harder to study. But I should note the prospective study data, the 200 prospective patients, those were across medical ICU, cardiovascular ICU, and I think a different surgical ICU. So our prospective data was across ICUs. So we do have data from medical and other ICUs on the prospective data set. And it appears that, yeah, that the same concepts should apply.
Okay, thank you to our audience for those great questions for Dr. Karon. We appreciate his insight on the topic. Unfortunately, we have to conclude the webinar at this point, so be sure to join us again and invite your colleagues to attend the next Nova Biomedical educational webinar. You can register at novabiomedical.com/webinars, where you will also find a full catalog of on-demand webinar offerings. So for Dr. Karon and Dr. Bangia, I would like to thank you for attending and wish you a great rest of the day.